Um, Good morning, good afternoon, or good evening, depending on where in the world you're joining us from. And I'm Dr. Vishwanath S., a senior consultant in the Department of Medical Oncology at Apollo Hospitals in Bangalore, and also the managing trustee and co-founder of CPOM Foundation, and your host for tonight. A very warm welcome to all of you to this ASCO endorsed CPOM Foundation webinar on access to multidisciplinary tumor boards and molecular tumor boards between the high resource and low resource settings. A few ground rules before we start. Please ensure that you have a stable internet connection throughout the session. All attendees must be in listen only mode, so kindly remain on mute. If you have any questions, please type them in the Q&A section. We will address them later during the discussion. And please note that this session is being recorded and will be available for later viewing. A few words about our foundation. CPOM stands for Creative Portal for Oncology, Education and More. CPOM is a not-for-profit organization tasked with educating practicing oncologists and trainees, and a portal for increasing access to patient resources and improving access and awareness globally. This is our CPOM team. Myself, am a senior consultant and academic advisor in the Department of Medical Oncology at Apollo Hospitals, Bangalore, co-founder and managing trustee of CPOM. And then we have Dr. Santosh Kumar Devdas, who is also the co-founder and trustee of CPOM. And we have Dr. Poonam Maurya from Apollo Hospitals, Dr. Chandrakant from Narayana Hospitals in Kolkata. And then we have Dr. Rachin Shetty from Mangalore, who is also a medical oncologist. They're all the co-trustees of CPOM Foundation. So this is the agenda for tonight. We have a very important keynote address by Dr. Julie Grallo, followed by setting the context to molecular tumor board access by Dr. Poonam Maurya, followed by a very important panel discussion on access to molecular tumor boards by Dr. Timothy Cannon. And then we have another introduction to multidisciplinary tumor board access by Dr. Rachin Shetty. And then we have a panel discussion on access to multidisciplinary tumor boards by myself. And then we have some closing remarks by Dr. Poonam Maurya. So let's move on to the very, very important session. We are extremely honored and privileged to have the keynote address to be delivered by the Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology, also the Professor Emeritus of the University of Washington School of Medicine, Dr. Julie Grallo. Will welcome you, ma'am. And Dr. Grallo will be talking on the role of multidisciplinary and molecular tumor boards in modern oncology care, addressing challenges in both high and low resource settings. Over to you, ma'am.
Thank you very much, Dr. Vishwanath. And I am going to share my screen. Let's see. There we go. So I appreciate the honor of speaking in CPOM, which we at ASCO have been supporting for several years now, and we're honored to be participating jointly in this webinar. I'm going to be talking about, as Dr. Vishwanath has indicated, the role of both multidisciplinary and molecular tumor boards in modern oncology care and addressing the challenges in both high and low resource settings. So let's talk about modern oncology care and why we need these tumor boards. First of all, there's been a shift toward more personalized medicine, tailoring treatment recommendations to both the patient and the tumor. So we need individualized discussions. It's not one size fits all. Additionally, we've had an increasing complexity of genomic data that is critical for making optimal treatment decisions. So multidisciplinary role in the modern era in navigating complexities of care. And the goals are to improve patient outcomes, to optimize treatment strategies, and to foster collaboration. These tumor boards have challenges that are unique to high versus low resource settings, as well as potential solutions. But I'd say there's a lot of overlap as well. So I'm going to first talk just a little bit about multidisciplinary tumor boards, and this goes along with that shift toward personalized medicine. And while I think most of you on this webinar are aware of what they are, we'll just spell it out. They bring together experts across specialties and disciplines, and that could include surgery, medical oncology, radiation oncology, pathology, radiology, but beyond, and not just across disciplines, but across professions as well. In the US, we've had the concept of multidisciplinary care and multidisciplinary tumor boards for a while, but it really came to light and came to the forefront in this 2013 US Institute of Medicine report on high quality cancer care. And in this report, it highlighted teams and teamwork as a crucial part of the solution to workforce shortages in oncology and the increasing complexity of cancer care. So in response to that IOM report, the USNCI and ASCO teamed up for a project called Teams in Cancer Care. And this resulted in a workshop in 2016 on teams in cancer care delivery. Out of that workshop, there was a full journal of the issue of the Journal of Oncology Practice with 19 peer-reviewed manuscripts focused on team-based care. Some of you may be interested in looking at that journal issue. And then there was a follow-up just recently in 2023 devoted to teams in cancer care with another 15 peer-reviewed submissions, many of which looked at where have we gone in that period. And I've put the links here where you can access all of the information about that workshop and all of the papers in these journals online. Now at ASCO, we embraced multidisciplinary care, multidisciplinary tumor boards. And one of our most popular international courses, we conduct many of them a year across the world, is our multidisciplinary cancer management course. And in these courses, we demonstrate, we pick a couple of tumor types to highlight. We demonstrate how multidisciplinary decision-making takes place, how it's important in the management of common cancers, and we use local case presentations and mock tumor boards. And as part of this, we talk about tumor board development and principles that are key to this course and key to multidisciplinary cancer care are that it be evidence-based, individualized to the tumor and the patient. We have discussion between all specialties and professions, and these are respectful. And we have, in the end, consensus treatment recommendations. So moving on to molecular tumor boards, this gets at the issue of the increasing complexity of the genomic data that's really required for optimal cancer care for many tumor types. And molecular tumor boards, their main goal is to interpret the complex genomic profiling data to guide treatment decisions. And in addition to the standard participants of a multidisciplinary tumor board, we involve geneticists, bioinformaticians, researchers, etc. So we need these molecular tumor boards because of what's happening in oncology. Precision medicine is really causing amazing improvements in outcomes for our patients. If we look at the US FDA's approval of oncology drugs over the past 2 decades, we've had almost 200 new oncology drugs approved, and 83% of these can be classified as molecularly targeted therapies, and 43% can be classified as precision oncology therapies, which means they require biomarker testing in order to know if they should be used. And alongside of that, just looking at this study that evaluated solid tumors, 47,000 solid tumor samples, comparing 2017 and then again 2022, they looked at what had happened in terms of actionability, meaning if we find a genomic abnormality, is there a drug that goes along with that that we should be considering? And this is just comparing across a 5-year period in the US. So tumors that had predictive biomarkers of therapy response that were eligible for available targeted therapies or immunotherapy in 2017, it was 8.9%, and that had increased to almost a third, 31.6%, just 5 years later in 2022. And then tumors with oncogenic, meaning there were alterations that were associated with the development and the driving of the cancer, but that were not clinically actionable because there was no drug available, decreased from 44% to 22.8% as more classes of precision oncology drugs became available. And we need to know about genomic alterations in order to have optimal treatment. And I put this up just to show how overwhelming it is now, just in non-small cell lung cancer. This is the ASCO Living Guideline. It's updated every 3 months because of how fast things are changing in non-small cell lung cancer. This is first line for those with driver mutations. And look at what you in theory have to know, because there are drugs available for all of these alterations. And right now, based on the drugs available, it's estimated that almost half of patients with advanced non-small cell lung cancer may have an actionable oncogenic mutation. It's overwhelming. The interpretation of next-gen sequencing reports is incredibly complicated. And so molecular tumor boards have a critical role. Things are moving fast. There's a rapid evolution of cancer genomics. We have a large number of variants of uncertain significance or equivocal copy number alterations. We don't know what they mean. And there's a continuous evolution in drugs and trials available, including this new category of tumor agnostic drugs. So molecular tumor boards help translate the results of these complicated genomic tests into clinical practice. We've already talked about the wide-ranging expertise that is needed. And unfortunately, this kind of multidisciplinary expertise in molecular results is often not available routinely outside of academic centers or integrated health systems. So why multidisciplinary and molecular tumor boards are important? One, they help improve diagnostic accuracy, and this collective expertise leads to more accurate diagnoses. They help with enhancing treatment planning with multiple perspectives to develop the most effective and personalized plans. They help with adherence to best practices and guidelines and evidence-based medicine. They help facilitate clinical trial enrollment because they help identify candidates for clinical trials. They help improve communication and coordination, and this results in much more seamless patient care. And they're great opportunities for education. They serve as valuable learning platforms for everyone who's participating. So let's talk about challenges in high resource settings. I've already shown you the data overload and the complexity with that non-small cell lung cancer living guideline, and then all the new drugs that are available. It can be overwhelming. It's complicated to start integrating all of what we call the multi-omics data, and beyond just at a gene level, a somatic gene level, we've got other transcriptomics, proteomics. We're looking at RNA, proteins, et cetera, to really best understand the cancer. Another challenge is access to advanced technologies and expertise. And in the US, most of these things are available, the diagnostics and the treatments for many patients, not all, but timely access to the diagnostics and the expertise to analyze them is still a hurdle. We've got challenges in workflow integration and efficiency, again, getting at timely recommendations. We do have cost and reimbursement issues, even in the US. They're not always covered. We have to get insurance approval and pre-authorization, and sometimes denied. And then there are ethical considerations that exist both in high and lower resource settings, ethical dilemmas related to incidental findings or data privacy and equitable access to these diagnostics. Challenges in low resource settings, many of the same challenges in high resource settings exist in low resource settings, but there is, in general, much more limited access to the multidisciplinary expertise with the scarcity of specialists. There are infrastructure limitations with lack of adequate diagnostic equipment, even just internet connectivity, secure data storage, financial constraints that exist in high resource settings, and they are much more magnified in low resource settings. Sometimes there's a limited awareness and education. That's what this webinar is all about. Healthcare professionals might not even know about the benefits of the implementation of both multidisciplinary tumor boards and molecular tumor boards. And logistical hurdles, some of which relate to geographical distances, workload issues, et cetera. So there are potential solutions and strategies. I know we're going to talk about these in our panels for both multidisciplinary and molecular tumor boards, and they apply across high and low resource settings. So a potential solution or strategy to improve access would be telemedicine and virtual tumor boards. Having standardized protocols and guidelines for both how to deliver evidence-based care, but also how to run these tumor boards. Capacity building and training, a solution to, or a strategy for improving access to these tumor boards is investing in training programs in both multidisciplinary collaboration and molecular diagnostics. Another solution or strategy is to prioritize what are the most essential molecular tests that should be run, especially when resources are limited. What will really make a difference? What are the drugs that have high value, the most high value? And maybe we can't test for them all and have access to every drug. We can have regional or national tumor boards across institutions. We should consider public and private partnerships, looking for collaborations that would help facilitate access to technology, expertise, and funding. We need to look at developing, and there are many of these tools that are being developed or in use right now, but user-friendly tools and resources to make the interpretation of this molecular data even easier. We need to advocate for policy changes to support the implementation and funding of molecular tumor boards and the diagnostics and the drugs that go along with them. And we really need to focus on proving the clinical utility of these tumor boards and the cost effectiveness. We need to continue to get the data that shows that these tumor boards both improve outcome and can potentially reduce long-term costs. So I thought I'd give an example of something I find very interesting in the United States for improving access to precision medicine. The American Society of Clinical Pathology has an interesting pilot on a cancer biomarker testing navigator. This is a lab-based navigator, not your typical patient navigator, social worker. This is someone with laboratory expertise who, when they see a cancer biopsy coming in to the laboratory, they immediately look for what would be the recommended biomarkers to be tested, get back to the clinicians who will be treating the patient, review them, and there's not a big time lapse between having the biopsy and then getting those tests back. The Association of Community Cancer Centers also has a somewhat similar project called the Precision Medicine Stewards to Improve Patient Access. And again, these are stewards or navigators that are tied to the lab, and they can help with the time from test ordering to result delivery, time from diagnosis to treatment, the percentage of patients who actually get complete biomarker testing, but also in these pilots, they help get the funding for these. They help with financial assistance and get the insurance approvals, make sure the patients don't get surprise medical bills, et cetera. They help improve the patient experience as well as the provider experience. In other settings, this is just an example of access to a molecular tumor board in Romania. And I'm happy to say that our Eastern and Central Europe Regional Council out of ASCO has prioritized molecular tumor boards. as one of their priorities they want to work on together across Eastern and Central Europe over the next couple of years. So in Romania, genetic and genomic testing was not available, reimbursed. But because of clinical trials and some funding, it became available for patients with metastatic breast cancer. And so they could afford to do next gen sequencing. They had it covered through the trial, but then they needed help with interpretation. So they partnered with Vanderbilt in the United States in their Our Cancer Genomes International Molecular Tumor Board. And they were able to participate in meetings that were held virtually monthly via Zoom. They've The focus of these discussions was on actionable alterations that the drug had some form of EMA or FDA approval, whether on label or off label. And they also focused on, was there a clinical trial available? And over a 3-ish year period, about 40 cases from Romania were presented, the majority triple negative breast cancer. In India, I thought I would just highlight how a strategy for getting access to targeted therapies. And so the National Cancer Grid of India is 300 cancer centers, research institutions, patient groups, and professional societies. And they are getting access to many precision medicine drugs through pooled procurement. So this is leveraging high volumes through aggregated demand. In a recent look, about a median of an 82% discount on the maximum retail price was achieved through this pooled procurement. The quality of drugs was ensured by selecting companies and molecules with pre-specified criteria, and supply chains were more reliable because the negotiations were done as a group, not small volume across individual cancer centers. Partnered with this is the National Cancer Grid's Traveling School of Pathology, where experts in cancer pathology and surgery travel around the country to hard to reach locations. And over 800 surgeons and pathologists have been trained through this traveling school of oncology. And for the future, I think artificial intelligence is certainly going to help us with knowing what are the tests that should be done. A while back, I asked ChatGPT as an exercise, what molecular and genomic targets should I test in metastatic non-small cell lung cancer to guide treatment decisions? And you see what it came up with. It told me the targets, and then it told me what drugs might be available. So increasingly, some of that knowledge that goes along with the expertise at the lab level and the molecular tumor board level, at least in terms of knowing what to test for, not how to interpret it, will come from AI. So in conclusion, about multi-tumor boards and molecular tumor boards in modern oncology care, one, multidisciplinary molecular collaboration have critical roles in advancing oncology care for all patients, regardless of their geographic location or their economic circumstances. There's a growing importance of patient advocacy and involvement in these discussions. We should remember that the focus is always back on having the best experience and the best treatment for our patients. And then continued efforts are still needed to address the existing challenges and to implement innovative solutions. And I'm excited to hear from our panel discussions about how we're going to implement and some of the innovative solutions as well. Thank you very much.
Thank you, Dr. Julie Grallo, for that wonderful global perspective on the access of molecular tumor boards and multidisciplinary tumor boards. And shifting gears, let's move on to the next session. We have Dr. Poonam Maurya, who is also a consultant at Apollo Hospitals in Bangalore and also a trustee of the CPOM Foundation. She will be giving a context to the panel discussion on the access to molecular tumor boards. Over to you, Dr. Poonam Maurya.
Thank you, Dr. Vishwanath. Uh, Lovely evening to everyone and lovely morning from wherever you are. So, setting the context, as oncology moves towards a precision medicine, molecular tumor boards have emerged as a vital platforms to interpret more and more complex genomic data and to guide us regarding the targeted therapy decisions. So, molecular tumor boards integrate molecular profiling, bioinformatics, and emerging biomarkers to personalize the treatment for a patient. In high resource settings, molecular tumor boards are increasingly embedded within the academic centers and supported by infrastructure like the NGS next generation sequencing or access to real time databases, molecular pathologists, and bioinformatic teams. They help match patients to the targeted therapies or clinical trials based on tumor genomics, contributing to improved outcomes and better utilization of the novel therapies available. However, in low resource settings, access to molecular tumor board is still limited by high cost, lack of genomic testing, and shortages in the specialized expertise. So even when sequencing is available, interpreting results and translating them into actionable treatment plans can be challenging without a formal molecular tumor board. So this underscores the growing need for collaborative cross-border molecular tumor boards, virtual platforms, and equitable access to molecular diagnostics to ensure that advances in precision oncology are not limited to a few privileged ones. As we explore this topic further, we'll contrast how molecular tumor boards function in different resource environments, and discuss strategies to democratize access to molecular oncology expertise. So, today, to discuss this, we have our elite panel members, and the chief moderator for the session will be Dr. Timothy Cannon, sir, and he is the associate professor at the University of Virginia and Sheldon Director at the Innova Molecular Tumor Board. Welcome, sir. And the other panelist members for this today's discussion are Dr. Ullas Batra. He is the founder and director at the and medical oncologist at the chief at the Rajiv Gandhi, New Delhi. Welcome. And Dr. Manjunath Ramarao. He is the chief scientific officer and executive vice president um, Aragen, and also acting chief scientific officer at the Atomic AI. Welcome. We have Dr. Charlene Gill, who is a professor of medicine and medical oncologist from the University of British Columbia, and Dr. Jason Weston, he's the director of the Lymphoma and Clinical Research Program from the MD Anderson Cancer Center. And I think Dr. Shubham Pant is not joining us. We have Dr. Aparna Dhar, who is the director of the Hereditary Precision Oncology and Genetic Counseling from Max Healthcare. Welcome. So over to you, Dr. Timothy.
Thank you, thank you for that introduction, and I really enjoyed Dr. Grallo's excellent presentation, and I'm really looking forward to learning from this panel discussion. So I thought maybe I would start with just an introduction to myself and the kind of system that I practice in. I'm a GI-focused medical oncologist in a suburb of Washington, D.C., and I think it would be fair to say that this is a resource-heavy area to practice oncology. We have a large hospital-based cancer center with 45 oncologists, and I'm one of 5 GI-focused oncologists. We at one time did our own genomic testing. Now we just do single gene testing and outsource our NGS, and that's the term I guess I'll use for next, sort of broad panel sequencing or next generation sequencing. And we have very little difficulty getting those tests. They really don't have much in the way of financial discussions with our patients about them. The system typically with commercial NGS companies is to bill insurance, take as much as they can get from the insurance, and never balance bill the patients. And so, in our system, believe it or not, of the 100 top problems I have as an oncologist, payment for these tests is not one of them. And I'm very interested to learn how that compares and contrasts with the rest of our panel. But anyway, that's, I think, a brief overview of sort of our practice environment. We also have a weekly tumor board, which I moderate and have since 2016. Unlike many other large American cancer centers, ours is not disease specific. We have one tumor board that all subspecialties participate in. So with that, I thought I'd just start by asking a few questions, and please feel free, as this is my first time doing this, so if people feel like there's a better format for this, or there may be a better way to facilitate discussion, please jump in. But I wanted to start by asking maybe Dr. Gill, how her, to just give an overview of her sort of experience with molecular testing and the resources that are available for her in British Columbia.
Thank you. Thanks, Dr. Cannon. I maybe by way of background, I'll also share my practice setting. So I'm based in Vancouver, British Columbia. So Canada is kind of in between. So we are a publicly funded healthcare system, which means that we have universal access to healthcare, but it's very sometimes it's very selected access to what may be funded, both in terms of biomarker testing and also in terms of funded therapies, especially trying to access something off-label can be very difficult in a publicly funded system. So in my practice as a GI oncologist, let's say, for example, for colorectal cancer, there are no barriers to access to companion diagnostics for known therapeutics. So the way biomarker testing is funded is it's linked to an approved therapy. The challenge becomes when you're trying to think about something that's more tumor agnostic or something that's maybe off-label, or thinking about trying to identify patients for clinical trials. So in that circumstance, we have a research program, which we can come back and speak to sort of how that might potentially increase disparity for patients in my province who might be outside the catchment of our academic center in Vancouver. But we have a research program which is called Personalized Oncogenomics, which patients can be enrolled in, twice weekly molecular tumor boards that includes bioinformaticians and geneticists, as well as the medical oncologists, to really discuss molecular precision oncology sort of options. And we use that again to direct patients to clinical trials and to also identify potential, off-label options. And then you get into the, discussion about how to access those therapies for an N of 1 off-label use. But that's sort of our environment, I think. But for RAS testing, BRAF testing, MMR testing, HER2, the usual sort of known molecular diagnostics are readily funded and accessible.
Dr. Gill, a quick question. In the U.S., we have two sort of broad basket trials. One's called TAPER, which is run by ASCO, and another NCI Match. Is there an equivalent to that in Canada to address the kind of the problem you were talking about, where you have a good
it's so we, through our Canadian Cancer Trials Group, have a trial called Capture, which is, again, depending on which arms are available, but that allows for, someone has, ERB2 amplification and, trying to get access to something on that arm. We also have, oh man, I just lost my train of thought. But what I was going to say was, like each individual program. So in Canada, probably the largest phase 1 programs are in BC and in Ontario, in Toronto. But Canada is a very vast country. So I think one of the challenges for us has been, for my patients who are in Vancouver, I think there are not access issues, but for patients who live in more remote areas, and I think that's true probably in any geography, access to molecular tumor board, to thinking about clinical trials as well is more challenging.
Got it. Okay, and so to add more color to the the North American practice environment, would love to hear from Dr. Weston. I work at a community hybrid type center. He's at a giant, academic NCI designated cancer center. So I'd love to hear if he would comment on anything that contrasts with what we said or complements what we said.
I am thrilled to join everyone today. This is a great discussion. And as you mentioned, we all have different versions of oncology of how we practice. And it's wonderful to kind of step outside of your lane and see how others deal with similar challenges. And we all have challenges. So at a large academic center in a resource privileged area, we, similar to as mentioned, have access to molecular testing. The question is how rapidly are they available and how actionable are they? And I think that's always the question of, can you do the test, but also should you do the test? Is there something that you're going to do as a downstream with that? And in hematologic malignancies where I practice, things have moved forward, but not quite as fast as in solid tumors in terms of actionable mutations or therapies that are targeted for a specific subpopulation of a disease defined by a biomarker test. So I think that it is a question of can you get the test, and then what are you going to do with the result? As an example, a readily available test that we use on a routine basis is the simple FISH test, the fluorescent in situ hybridization, looking for genomic translocations of a few relevant genes. Those are tests that are available globally. They are expensive. They're not tests that are without cost, but they do have an impact on our treatment algorithm in terms of, if the test shows an abnormality, we give this chemotherapy. If it's not there, we give that chemotherapy. And so I think that this discussion today is wonderful about different backgrounds, different practice patterns. But at the end of the day, what is the impact on the patient that's sitting on the other end of this conversation? I think that's always critical to keep that in mind of what is your intention for doing the test. And in our practice, we are mindful of that. Even though we have access to these tests, we always look at what is the net benefit for our patient.
Right. And to that point, in our with our partners here that are practicing in a low resource setting, of course, anything they're using must have high yield. I'm sure there's an extra pressure to have that high yield. So I'd love to hear from Dr. Dar and Dr. Batra, and any others that want to chime in. Can you tell us, in your the setting you practice in, what predictive biomarkers are currently tested for? What do you have access to right now?
Dr. Aparna, can you take it?
Sure. Go ahead. Why don't you go ahead and then I'll follow.
Okay. So just to briefly follow up on the earlier introduction slides, in the LMIC context, we are in the M of the M. That is the middle of the middle countries, middle of the middle income countries. We sometimes have the best of all the worlds, and we sometimes have the worst of all the worlds. So we have the best of all the worlds because we can order whatever test we want. We can order a single gene testing to a foundation, to a combined liquid and tissue biopsy from Guardant. That again depends upon where you practice, basically what the patient can afford. And India, again, Canada is a large country, but India is a heterogeneous country. If you ever have to look at the heterogeneity of a region, you should look at India. You have the Ambanis and Adanis creating a wedding, and people sometimes don't even have 2 meals. So just to cut it short, the place where I practice, it's a trust hospital. I am a medical oncologist with special interest in lung. We have our own in-house NGS panel. We do single gene sequencing. We do in-house NGS testing. We have different panels for lung. We have different panels for colon. We have different panels for the endometrium. We have a CGP. We have a liquid biopsy. We also can outsource these tests if we want. Patients typically in India do not pay, the insurance doesn't really cover much of all these tests. That's the biggest thing, but people pay out of their own pocket. So what we did with lung cancer, where I typically specialize, is I sat down with my molecular oncologist and we made a panel of a 50 gene panel, which included a DNA, RNA, and we customized that panel to all our needs. And so we do NGS, and what we also then did was we asked some of the pharma companies to co-pay it. So right now, the NGS panel that we use it in our lung cancer patient is $100. And we get the EGFR reporting in 3 days time. We get the ALK reporting in 2 days time. We do NGS for everyone who comes to us with lung cancer. We do NGS for everyone, the short panel, not the CGP.
We do a small 34-50 gene panel for everybody who comes either with a squamous lung cancer or adrenal lung cancer or something. So that was the best of all the words. The worst of all the words is sometimes we don't have the medicines for that. If you look, I was just looking at that, let's say you get a KRAS. Okay, we have clinical trials, but we have clinical trials for a population of 1.4 billion. The clinical trials are not good enough. I was just hearing you guys saying about, you have NCI and US sponsored and capture sponsored. There is no one regulatory authority in India which sponsors these trials. So in my institute, I may have 25 clinical trials going on, but that is individual and an institute specific. Similarly, in a hospital.
Oh, I'm so sorry to stop you. This is all, I wanted to just go back for a second. So do you actually ask your patients then to pay for this, this sort of multi-gene panel, $100? Is that something
Yes.
you
So
have a financial discussion?
copay. Yes, we have a discussion with them. So normally insurance covers only less than 15% of all the healthcare facility in India. Even in the best of scenario, the insurance doesn't cover more than 30-40%. The government also only pays for 20%. Most of the people don't have insurance. They more have government aided things. So people pay out of their own pocket.
And in the end, how many people, what percentage of your patients are actually having this panel done, would you say that you see?
Anybody and everybody who comes to us with lung cancer gets 80%, 90% people will get the lung cancer panel done at the beginning of their thing. So we did an analysis actually way back in 2018 or 2019 when we were doing a big panel. We were doing a single gene testing, EGFR, everybody used to get. More than that, not more than 30%. But now 85% of all our lung cancer patients, and that includes squam, non-squam, and I'm talking about a figure of around 700 lung cancer patients per year. We do NGS.
Yeah, that's interesting. And then getting to the drug access side, you were saying that's more of a problem. So would you say that among your patients that have an EGFR mutation or ALK, ROS1 fusion, or whatever, the common ones, what percentage of them are accessing a targeted therapy?
For the common one, for EGFR, we have everything available. We have osimertinib, we have amivantamab. For ALK, we have lorlatinib available. For ROS, we have a trial which gets Trident trial is there, which is getting repotrectinib. We have entrectinib and crizotinib. The more issue is about the RET, where we do not have selpercatinib. About the KRAS, where we do not have sotorasib or adagrasib. HER2 is available. For HER2 new, it is available. Entrectinib is not available. So yes.
I see.
But they are costly. They are very costly drugs. So again, they have to pay out.
When you say they're costly, are you talking about the ones that you describe as inaccessible, or are you describing the ones that you mentioned where you do have access?
So, if you look at the common ones, EGFR and ALK, they are very, very, if you look at the cost that probably you will have to pay in US versus what we have to pay, our cost is probably 1/10 or something, which is there because even the pharmaceutical companies have subsidized this for the LMICs. But for the ones which are not available, like selpercatinib or repotrectinib or something, those are the costs in HER2. That cost is usually out of the bounds for most of the people.
So, Dr. Batra, in your practice setting, is it accurate then to say that your challenges have much less to do with the testing? I mean, you even mentioned along the way that you have a molecular pathologist, I think, if I heard you right.
Yes.
And much more to do with drug access.
Yes.
I would love to hear if that is similar. Now, are you in the city of Bangalore, or where is your practice? And
I am in the city of Delhi.
Sort of the reality in most of it, India.
So most of the times, I think let's around 20 to 30% of people. Okay, so how many people will have a molecular pathologist in the hospital? I think less than 10%. Aparna is a molecular pathologist. She will tell you more about that. Less than 10%. Okay. But, we have a lot of companies. So we can outsource the test. And there are a lot of people who provide with these tests and they have access to the molecular pathologist. Aparna, if you can comment on that.
Sure, absolutely. Thanks, Dr. Ulas. Hi, good morning and good evening, everyone. So I work out of a private hospital, so our practice is a little bit different from Dr. Ulas's. Usually the patients that come to us are those who pay out of their pockets, yes, are somewhat slightly more affording than possibly what we see at RGCI and a lot of the other centers, but we also cater to patients that are not that affording and do not have insurances that could potentially be, covering their treatment. So I am a geneticist by training, a molecular geneticist and a genetic counselor by training, and I look after molecular oncology and cancer genetics wing for a hospital chain called Max Healthcare. So I cater to all our Maxes across India. So one thing that I kind of echo with what Dr. Alas is saying, it's pretty similar. Yes, ideally, when we have a patient, we know in a case of lung, even biliary tract cancers, we try, biliary tract, pancreatic, colorectal, at least the basic, we try as much as possible doing upfront, maybe not a CGP, but at least a newly diagnosed, stage 3 metastatic, where we know these molecular targets could have a role in guiding treatment. Ideally, that's what we like to do for our patients. If not NGS, at least maybe RT-PCR, FISH, IHC. I think one thing that we can all be very proud of is that even our second tier, third tier cities, which has a cancer department, does have a, I wouldn't maybe say the best, but at least the basics that is required from a pathologist and an oncopathologist, like basic ER, PR, HER2/neu by IHC. So these facilities are available. They may not have a FISH and may.
And I'm sorry, Dr. Dar, I think we've somehow lost her connection here. I was wondering if there's anybody else that practices in a setting at our hospital. Oh, I'm so sorry, Dr. Dar, go ahead.
Oh, I'm sorry. Okay. So these options are available to our patients. Something that we practice in our hospital is at least once a week, we run a molecular tumor board. So you'll have the medical oncologist, surgical radiation, the genetic counselors, the geneticists, the pathologists getting on board and discussing all our NGS reports. And especially if we have to do something off-label, or, especially with this complex reports like Foundation, Garden, Tempest. We are trying to do this as regular practice. We are doing it, but, and trying to bridge that geographical gap that is there, between the various hospitals and second tier, third tier cities. So molecular tumor boards, virtual molecular tumor boards have helped shape and make a difference, but it's still work in progress. There is a pan-India molecular tumor board that happens where we have actually experts from pan-India, we have experts from the US, UK getting on board. And, and this is primarily for those in the second tier, third tier cities who are doing next generation sequencing, do not have access to maybe organ-specific medical oncologists or organ-specific surgical, molecular pathologists. So these little initiatives are being taken, but it definitely, we still have quite a mile to go.
Dr. Cannon, we also have Dr. Manjunath, who is also a translational scientist. He can pitch in.
I'm sorry about that. Dr. Manjunath, I'd love to hear from you too, maybe particularly about whether you feel that sort of the expertise gap is less of a problem than the access gap.
Yeah, no, I think, so the access is definitely a problem because in the what I have seen is, especially in the rural areas and people who are do not have access, direct access. First of all, access to good hospitals and good centers and also affordability will continue to be an issue for them. Secondly, in a bigger sense, from a translational perspective, I understand that we were still able to do some of these hotspot mutation testing, panels of mutations, and which are all in a way based upon the Western or the Caucasian population data or the US based data. My concern is that how much of the for example, Indian subcontinent data are we really looking at? And for example, if you're looking at lung cancer or oral cancer, which is quite prevalent here, what type of mutations do we see here, which are more, or which are similar or different than what we see in the external, in the Western world? So I think having a genetic database or a genetic registry of sorts, which kind of in a way, I understand that there have been a lot of work going on in that area, but I think having a systematic analysis of the tumors and tumor mutations or tumor mutation burdens or resistance mutations that developed after some of these treatments, I think that needs to be in place, because when we talk about treatment options, for example, G12C, G12C KRAS mutation. I mean, let's say we treat it, and then when we're going to see some mutation in EGFR, I mean, is that the same pattern that we see here, or what mutations, additional mutations are coming in, or when you're looking at IO therapy, are we really looking at mutation burden, tumor mutation burden, and what type of mutations are we seeing there? I think understanding some of those fundamental things will be critical for utility of some of these medicines here in the Indian subcontinent.
And Dr. Manjunath, in India, what do you think is the more likely venue in which to do that data indexing and drill down on some of those issues you spoke about? Is that something that it sounds like from other comments that maybe there's not sort of that system set up in government, or that central system? Is it something that could be done by an Indian-based molecular company, or is that something that should be done within the government or a medical society, or what? How do you think that would be best accomplished?
I think there is some aspect from the government organizations which are actually trying to build this data set and database. I think the doctors who are actually practicing may have a better view on that. But I think it's also important for the hospitals to come together. I think that I don't know how much of that is happening because there's so much of learning and so much of data that is already being generated. Now, is that data available for in general the physician population or the oncology population, oncologists, for example, to take action? I think Dr. Gralo actually talked about it really well, all the challenges that are there. I honestly think that the AI/ML option could be a huge option to look at, because that kind of removes, once we have the data, that removes at least the first set of support system for oncologists to make decisions or to take action. I think that can be a huge tool, easier tool. I think I would love to hear from the other doctors in terms of getting the registry or getting how do we collect this data and how do we propagate or get this database in place, and how are we using that would be helpful.
Any comments on that?
So I think I'll like to come here, Dr. Cannon. Okay, so as I said, India is a heterogeneous disease, it's a heterogeneous country. You spoke about the middle of the middle from me and slightly up on the pathway from Dr. Aparna. But there are a lot of people who do not actually have access to a single gene testing also. So you talk about a second tier city, a third tier city, where even getting a single gene testing also is an issue. So if we all spoke about our individual experiences, but if you look at an entire country, does everybody have access to that? I think that is what probably you wanted to know. No. I mean, the long and short answer is no. A lot of people don't even get a single gene EGFR testing. So that's what we have. We can go on from single gene to a CGP in a span of 100 kilometers. That is exactly the problem which is there. So one, in a tier 2 city, a tier 3 city, there is no real forget about the molecular tumor board. The access to a single gene testing also is not there. So we definitely need more people, more companies to come in, the more government initiatives to get in NGS done in-house, or maybe collate the data. The second thing which is there is, can we and should we collate the data? I think that is the need of the hour. We have data, let's say we are a large hospital in North India. I have my own data. We have a large hospital in West India, Tata Memorial, they have the data. Somebody from South will have the data, but does our data talk to each other? No, it doesn't really talk to each other. Again, I'll tell the reasons. We and Tata Memorial, we thought we'll club in our data together. Now we did a 34 gene NGS panel. They did a 50 gene NGS panel. Something which was more over there, we did a PDL1 by SP263, they did by 22C3. So sometimes, that heterogeneity of data also can be an issue. So we need some measures to really put our data all together into one format. I hope this answers your question.
Fantastic. And some of these problems are familiar to those of us on the panel from the US, and some are not. Certainly the one you mentioned about not sharing of data, what we consider data silos, is one very familiar to us, and that also perplexes the US oncologists. To move on to sort of solutions and what a panel like this might suggest for ASCO or for other bodies that are interested in bridging gaps. It sounds to me like you are, you're mentioning that drug access is a primary problem. Testing, especially in second and third tier regions or hospitals, is an issue. Access to decision support may be a little less of an issue than those top two, but still is something worth addressing. When you think about sort of what would be an ideal way to collaborate with internationally, are there any ideas that come to mind about how some of these issues could be worked on?
So first thing which comes to the top of my mind is probably standardization of the NGS panels. I mean, you cannot have 12 gene panels, 50 gene panels, 55 gene panels, 200 gene panels. At least the basic minimum has to be there. And then we can probably go over we can go on to the next one. So I think the basic minimum step is if there can be a port. So let's define common minimum number of genes. Forget the lung, maybe in colon, maybe in endometrium, the way it is done. So basic standardizations of the NGS panels. That for me, no data silos, probably data lakes.
For both for quality and to also make sure that you're efficiently getting the most for your money out of your resources. Is that the idea?
So for me, the first and the most important thing is there has to be a homogeneity in the way you test. There has to be a homogeneity in the way you report. You cannot have 5 different people reporting 5 different things. So for me, homogeneous reporting system, if you see, if I order a foundation medicine or if you order a foundation medicine, the report comes the same, right?
Yes.
So,
right.
So the point over there is there has to be a homogeneity in the way you report in the so there are guidelines. It's not that guidelines are not there, but then probably have a structure in which everybody can put in their reports on that, which is accessible to everyone for basis of research, and then develop, as Dr. Manjunath was saying, an AI model or something of that sort. And then probably, like, you have the CDC website, look at the trials that are all running, easier things, simple, very little simple things. Okay, fine, you got this mutation. These are the trials which are available throughout the country. You can go here or there. Somebody needs to. Yes.
Yeah, go ahead.
Go ahead, Dr. Kannan.
Well, yeah, I was going to ask, like, some sort of declaration of or expert body giving what should be sort of a minimum standard for molecular testing would be helpful. Yes. Is that the idea?
Yeah. So a common minimum program is what we normally say. A common, at least the basic minimum things need to be there. You want to garnishes, you want to do this, absolutely fantastic. No worries about that. But at least a common minimum standard of reporting, and a common minimum system in which the data has to be fed properly. Yeah. So yes,
an expert body declaration like that is something that would help.
It would help a long way. ASCO, come over here. We all swear by ASCO. We all swear by NCCN. Whatever you guys say is the gospel truth.
By the way, you're talking to someone with absolutely no power. I'm just interested in.
No, I'm just telling you.
Here, but this is fascinating. I just kind of wanted to dig down on what, sort of what the ask would be. What any other comments from members of the panel?
Dr. Dhar has a comment.
Yes, I just actually wanted to add on to what Dr. Ullah said, that when he spoke about reporting standardization, I think it really boils down to the training. There is a lacunae of trained molecular pathologists in the country, trained molecular geneticists. Molecular oncologists in the system. I think automatically you will see a change in the quality of reporting, testing. So the issue starts right from DNA extraction, from wet lab to dry lab to your bioinformaticians, your bioinformatics pipeline. So while we're trying to standardize this test, if you don't have the right personnel to do the work, this will not, I don't think it will materialize, and we may not get the output that we're looking for. So I think education training is extremely important, that this is a minimum prerequisite. This is a basic training that anybody who is going to be practicing in this area should have at least. I feel that's an area that's lacking. Unless, Dr. Las, your comments on that.
I think a major educational course from the molecular pathologist to report and for the clinicians to act. Sometimes you act on a VUS report, sometimes you act on a 1.2% VAF on EGFR and see what happens. So, standardization in reporting, standardization in understanding, maybe an accreditation course, something can come up, maybe, a certificate course, something of that sort, which will help us, if you want to get the things right, education is the most important thing. Educate the people, things will become absolutely better.
Have you had an experience where an educational program like that has been helpful that you've engaged in? And what was the format of that?
Dr. Aparna, the Guardant one, go ahead, ISLB.
Yes, I was just going to say one was ISLB had done it. Dr. David Gandera and Dr. Natasha Lee led that. So that was more in the space of liquid biopsy. But even Foundation Medicine had done a tie-up with the Sidney Kimmel Institute, where it was a molecular oncology program. And honestly, you could see a difference in, the understanding and the education that it made to all the medical oncologists predominantly, who I think was primarily for the medical oncologists. Some of us just tagged along. But it was a phenomenal, education program that was there and was very beneficial and very well received. So one thing that I always appreciate about, our part of the world is that all of us are always hungry for education. So everybody is ready for, you give them a program, you give them a course, you give anything, and Dr. Ulas is one of the key people who I know who does this. But all of us are all very eager beavers when it comes to learning and improving and getting better. And it's across the board, from the junior most to the senior most individual in practice. So we did see great outputs with the ACMO program. I think that's what it was called from.
Yeah.
One more point, I think, Dr. Cannon, is, I always tell my residents, it's very important what not to do. What to do, anybody will tell you. What not to report, how not to treat, when not to treat.
Right. I
Dr.
agree.
Cannon, can we have last few comments and conclude this panel discussion?
Sure. Yes. And if I may, I would just want to hear if any of the other
Dr.
panelists have.
Weston and Dr. Gill, if they have to add anything.
Yeah.
Yeah, I think just kind of listening to the when Dr. Ulas talked about the heterogeneity within India, not just practice environments and population and access, I think I see huge opportunity in terms of trying to democratize access to, like you said, your common minimum sort of standard for molecular testing. And I think that's where, again, guidance from organizations like ASCO is so helpful to level that playing field and to broaden the access as much as possible. And I think, again, coming from a public health system, I think we are in a resource constrained environment in Canada from a healthcare perspective. And so there's a lot to kind of, a lot of common challenges and opportunities. So I think it's a great discussion and really congratulate the panel.
Dr. Weston.
Thank you.
I would just add that I think the role of this meeting today of CPOM and ASCO coming together, this deals with the problem of having everyone in their own silos and having their own data and their own same problems, but different approaches how to deal with it. Convening together and figuring out common solutions and having this forum and further discussions using this group, I think is really important for countries like India, as well as across the globe, to try and unlock these data silos, learn more from the patients that we currently are treating with approaches that we think are the best, but that we could do better in the future. And so I congratulate the CPOM team on putting together today's webinar, but hopefully this continues down the road with additional efforts to try and join forces and work together for our patients. Thank you.
Yeah, well said. This has been incredibly informative. Some of the really important issues we barely scratched the surface of, including drug access, and I would love to hear more about that. But yeah, just a tremendous discussion. Thank you for everyone that participated and for allowing me to be on this panel. And I look forward to future extended collaborations.
Thank you so much, Dr. Cannon, and all the panelists for that wonderful insights. Moving on, let me request Dr. Rachin Shetty um, to give a context to the next panel discussion, that is setting the context to the multidisciplinary tumor boards. Over to you, Dr. Rachin.
Thank you, Dr. Vishwanath. Moving on, we will be going to next session about multidisciplinary tumor boards. As we know, multidisciplinary tumor boards brings together all specialists, especially oncologists, radiologists, pathologists, surgeons, and palliative care experts, and sometimes in organ-specific specialists, and to collaboratively discuss and determine optimal treatment plans for better patient outcomes. In a high-resource setting, these boards are often well-established, supported by robust digital infrastructure, seamless access to imaging and pathology, and the availability of all relevant specialists. And this fosters personalized and evidence-based cancer care and often results in improved outcomes. So in contrast, in low-resource setting, access to molecular tumor boards can be limited or even absent in rural areas. Barriers include shortages of trained personnel, inadequate diagnostic tools, lack of digital connectivity, logistical challenges in coordinating meetings. Often a single clinician may have to make complex decisions in isolation, and it generally can compromise care and quality and consistency of care. That said, innovative solutions are emerging, such as virtual tumor boards, regional hubs, and public-private partnerships, which are helping bridge this gap. And but systemic investment and policy support are critical to scale these solutions equitably. So as we enter today's discussion, I look forward to exploring how we can ensure all patients, regardless of where they live, benefit from multidisciplinary decision-making in cancer care. This session would be moderated by our founder, Dr. Vishwanath S., who is a senior consultant oncology in Apollo Hospital, Bangalore. The panelists would include Dr. Prashant Penimadu, Medical Director and Surgical Oncology HOD of Sri Venkateshwara Institute of Cancer Care and Advanced Research Center, Tirupati. Dr. Santosh KD, Professor and Head of Medical Oncology, Ramaya Institute of Oncosciences, Bangalore. Dr. Anish Chakpar, a Professor of Surgery and Director of Breast Center, Yale School of Medicine. Dr. Govindarajan, Senior Consultant in Radiology and Head of Onco Imaging at Apollo Hospitals, Bangalore. Dr. Neeta Somaya, Chair and Department of Sarcoma at MD Anderson Cancer Center, Houston, Texas. Dr. Vinay M. Ural, Senior Consultant Radiation Oncologist at Apollo Hospitals, Bangalore. Over to you, Dr. Vishwanath.
Yeah. Thank you so much, Dr. Rachin. And we have a wonderful set of elite panelists tonight for this access to multidisciplinary tumor board. And after that wonderful moderation by Dr. Timothy Cannon regarding the molecular tumor boards. So let me start this panel discussion with a question to Dr. Anish Chakpar. She's a surgical oncologist with the Yale Cancer Center and in New Haven. So what is your perspective on multidisciplinary tumor board, and how often has it helped you in decision making, or has it changed your decisions following the multidisciplinary tumor boards?
Yeah, so thank you again for the invite to participate in this panel discussion. I think what we've heard so far in this whole discussion is how complex cancer management is, and how it's increasingly becoming more and more complex, with different parts of the team each bringing their own perspective. So I think the multidisciplinary team meetings really allow us to learn from each other. So going back to Dr. Dar's wonderful comment about being a sponge for education, I think part of that education is learning from each other within these multidisciplinary teams. Each of us brings our own perspective, our own wealth of knowledge, and the knowledge in each of our specialties is growing at such a rapid pace that we each are a little bit siloed, and we know that each specialty impacts another. So in the area of breast cancer, what the medical oncologist does in terms of their neoadjuvant therapy is going to affect me as a surgeon, is going to affect radiation, will affect whether or not the patient has immediate reconstruction and with what. And so coordinating care is one piece. learning from each other about the latest advances that may help our patients is another piece. But I think that it really is important that we have those discussions, because while many cases may be standard, there are cases, particularly those that are more complex, that really benefit from that multidisciplinary engagement.
Yeah. Very fair thoughts, Dr. Chapar. In fact, this was a review which was a systematic review, and it included a large study and included actually 13,000 different articles and included colorectal, lung, prostate, and breast cancer as well. And what has been seen in this review is that the multidisciplinary tumor boards, like you said, has significantly changed the outcomes as well as the treatment plans. Treatment plans were changed between 1.6 to 58% of the patients, and not only that, whether the patient type of surgery and reduction in overall performed surgery, the requirement of CT, MRI, and of course the outcomes have significantly changed based on this particular multidisciplinary tumor boards. Next question again to you, Dr. Chapar. What do you think about the information overload and fragmentation? There's so much of medical information, and you have so many departments all coming together, and so much of fragmentation and information overload. What do you think would be a good way to circumvent this kind of burning problem?
Well, I think back to the original point of multidisciplinary tumor discussions, right? There's no way for me to know everything about everything. I can know a lot about a little. And as we bring those pieces together, we can start putting that puzzle together. So I think multidisciplinary tumor discussions really do help with that. I think the other piece is that we need to think about the other things that we often think are outside of the sphere. So, we heard earlier about multidisciplinary tumor boards, I think in Julie's discussion, being a venue to think about clinical trials. We may involve, for example, even here in the US, where we have some patients who have financial issues, have transportation issues, have social issues, having the social workers, the nurse navigators come to those tumor boards. That way, everybody gets knowledge about everybody else's piece. So this fragmentation then becomes less fragmented, because we can bring all of those pieces together.
Yeah, well said, Dr. Chakpar. In fact, optimizing meeting structures and providing training support. And there are also certain support systems like the Adopt Clinical Decision Support Systems, which can be used. And all this put together, I think we can make the MDTs much better. And that would be probably the solutions, like you said. Moving on, Dr. Prashant Penumadu, again, he's a surgical oncologist working in a public hospital in Tirupati, which is a large city in southern India. So, Dr. Prashant, I'm sure you have a very, very busy practice, and with your busy clinical schedule, how do you manage to get all the specialists for a MDT?
Yeah, thank you, Vishwanath, for the invitation, and thank you, ASCO, for one of the, I think an exciting session so far. As you rightly said, it is a really challenge to get all specialties. And I can tell you that I have never conducted a tumor board with all specialties available. So this is something that which is real challenge. So what we tend to do instead is, we try and keep them pre-informed. Like, let us say we have a planned tumor board list that actually comes in, and it is practically impossible to do it on all days. So we have a structured day that we do twice a week or something like this. And we have a planned patients that are going to be discussed on a tumor board. Considering the volume, it may be practically impossible to discuss each and every patient that goes on for treatment. But if the patient requires some form of a discussion, then these patients are mandatorily discussed. So pre-planned, we may say, okay, we would need a nuclear medicine consultant to be on the board today because there are certain things that needs to be discussed. So I think that having it more structured would actually help us, get in as many people as possible on that particular day and make it possible for better discussion and meaningful discussion.
Yeah, I think very valid points. Most of the times, I think we have those mini tumor boards, and structuring is the way to go. But having some dedicated time for these multidisciplinary clinics would also help. Like you said, optimizing the meeting structures and of course leveraging technologies in this era is also important. Another question to you, Dr. Prashant Penumadu. So we are from a low and middle income country, and surgical oncologists, I'm sure you have come from JIPMA, which is one of the largest center in India, and surgical oncologists often operate in resource constraints environments. And how do you think MTTs help in triaging or optimizing surgical care in such settings?
So yeah, I mean, I would partly agree with the statement and partly disagree to Vishwa. So yeah, we may be operating in resource constrained setting, but the quality of surgery actually does not depend on what needs to be done for the patient. Whether you're operating in a public setup or whether you're operating in a private setup, I think the quality of surgery is something that remains the same, because if you're not adhering to that particular quality of surgery, then I don't think you should. I mean, in a center that is trained to do oncology, then probably you should not be looking at that. Yes, there is prioritization of surgical cases. That is something that which is important, and the waiting lists are quite long in patients in public hospitals like ours, and wherein we may have to prioritize patients based on their outcome or based on their predicted outcome, and then give try and reduce as much as delay as possible. But these delays are sometimes inevitable in a public hospital like ours. And yes, so yeah, for the surgical thing, I don't think it really makes much of a difference. But the tumor boards, the MDTs actually does make a difference, especially when you're treating with something which is out of the box, or something that which you are not convinced that which you should be doing. I think MDTs plays a real role in improving outcome in these group of patients.
Sure. Very valid points, Dr. Prashant. Thank you. So let's move on to our radiologist, Dr. Govindarajan. So what do you think are the biggest barriers you face in your daily practice, especially when it's from a radiologist who is trying to contribute and give inputs to these MDTs, whether it is connectivity time, or what do you think are the major challenges? I'm sure we keep discussing day in and day out in the hospital.
Yeah, Dr. Vishwanath, this is a good question, because one is this is the low-income countries have challenges with respect to resources, which can affect almost all fields. But when it comes specifically to oncology and multidisciplinary tumor boards, most important factor is there is no specific allotted time in many places. Of course, this is very, very different in different centers. Like for example, in Tata, there can be very, very well structured tumor boards. Whereas in a government hospital, like say for example, Bangalore Medical College, even though there are tumor cases, the arrangement for conducting such tumor boards may be very, very ordinary or suboptimal. In those scenarios, doctors will be very much, or particularly radiologists will be very much occupied with their clinical work. There is no allotted time for them, so they'll have to get some time during their busy schedule and come to the tumor board meetings. That is point number one. Point number two is many places the equipments may not be available for optimal imaging. And again, even if the equipments are there to visualize those images, maybe unstable internet facilities. That's again one of the major problems which can consume a lot of time. At the same time, doesn't really go well with the entire meeting. Apart from these things, which are again in general to most of the radiologists across the country, the imaging protocols can be very varying in different places, and you cannot ask a patient to go for imaging again and again just because he has got a scan done somewhere else. So you'll have to do away with getting a scan in your own center, but you'll have to compromise on the quality of imaging. Now, this is again one very, very important factor. The next factor is the human resource. You will not have subordinates who can help you out with your presentations, or who can help you out in getting your images to your desk. So you'll have to do all on your own. And the interpretation of the images is also a major factor, because not all of them will be trained in high-end oncology imaging. And very, very importantly, it may be the last point, but definitely not the least one, though this point is changing. There is a hierarchical system in our medical system in our country, where many places radiologists are kind of considered only the service providers, and many places they'll not be taken to the central point where patient care decisions are made. Even though this is changing in the last few years, particularly in major institutes and corporate hospitals, many other places it remains a subspecialty where it is not given due importance when it comes to patient care. So these are some of the challenges that we generally face. Of course, so I mean, it's not all of them can be there in one center, but in some centers or most of the centers, these are some of the problems that we face.
Great thoughts, Dr. Govindarajan. Again, another question to you. Your thoughts about teleradiology and AI. Now you talk about radiology, AI comes into picture. I'm sure it cannot replace the human mind, but then human eye as well for a radiologist. What are your thoughts on this?
Yeah, so I think a decade ago, when AI was getting inroads into the medical field, particularly into radiology, people thought that AI will replace radiologists, but the statement has changed these days. So these days we say, radiologists who don't use AI will be replaced by those who use it. So now I consider AI to be a wonderful assistant for myself. So I can give a lot of mundane work to the AI, and it can also help you in lesion detection, particularly in the setting of say, for example, mammography screening. You can use computer aided detection, and lung cancer screening, nodule detection. All these things are possible. Second thing, what AI can do is workload management. Third thing is standardize the reporting protocols. So you can feed your protocols into the AI, and it can generate the reports, and this can be done by anybody later on. So these are some of the very, very useful things. Additionally, as you said, we rely upon, say, for example, AI for mundane things, which can help us avoiding this exhaustion. I mean, alert exhaustion. Whereas I am very keen on something more, where I want AI to help me out in what I'm not able to see on my with my naked eye, for example. So for example, tumor architectural assessment or texture assessment. So these things can be utilized for maybe predicting tumor response. So that's a different field called radiogenomics or radiomics, which is coming up very, very fast in the last few years. So that is one of the things which is really fascinating to me as far as AI is concerned. And teleradiology, you asked me again about the teleradiology. Again, it helps a lot in connecting people where even in a remote center where a subspecialized radiologist is not available, you can have a subspecialized oncoradiologist or oncoimaging specialists who are not on board within that center. So this is one very important thing. And second thing is second opinions are possible. You can have access to services from experts in different fields in subspecialists. So these are some of the benefits of teleradiology in
Thank you, Dr. Govindarajan. Wonderful thoughts. So I think Dr. Govindarajan has summarized everything beautifully. Let me move on to our next panelist, Dr. Santosh Kumar Devdas, who is also our co-founder of CPOM. So Dr. Santosh Kumar Devdas, you're from a busy private center, very, very busy center. What do you think about video MDTs, hybrid MDTs? Do you think it can really help with the urban-rural divide? And also, what are your thoughts on the digital media like WhatsApp? India, we have kind of, we use WhatsApp so much in India. And what do you think about how it has helped with the accessibility to MDTs, with the real-time communication with all the specialists?
Thanks, Dr. Vishwanath. It's wonderful discussion till now. I enjoyed every minute of this webinar. definitely, we are moving towards a kind of a US model where there are organ specialists in academic centers in the United States. Similarly, in India, we see more and more organ specialization happening, especially in larger referral hospitals, uh, who can guide physicians who are doing general oncology in a more rural setting. And this we are seeing more and more, and we definitely have taken up WhatsApp in a big way. Though with WhatsApp there are privacy issues, uh, we are using WhatsApp to share doubts, have discussions in various platforms, and definitely improve patient outcomes. And with better access and better education that is happening in India, we look forward to more and more tumor boards improving patient care in our country.
Yeah, I think very valid point which Dr. Santosh mentioned. WhatsApp, most important thing is privacy issues. Things have to be encrypted, and I think, lot of issues. But the real time communication with our specialists is very easy, on WhatsApp. But again, privacy issues. Next question to you again, Dr. Santosh. See, in low and middle income countries, we saw Dr. Ullas Batra talking about we have NGS, but we do not have drugs, accessibility, so many things are there. But then what are your, in your MDTs, how often are you able to adhere to the conventional guidelines of, say, ASCO, NCCN, in your day-to-day practice?
I will just use a recent example of a management of CS cervix, locally advanced CS cervix. There was a recent publication called the Interlace trial, where there was a huge improvement in outcomes with neoadjuvant chemotherapy with the paclitaxel and carboplatin, yet to be part of the NCCN guideline. And there is a huge discussion whether we need to really use this data. And finally, after a lot of discussion, we did decide to use the Interlace data in our patients. So these are the situations where things are yet to come onto the guidelines, but the field is moving so fast. We have to be updated in the literature, and even before the guidelines have them among their set of rules, we have to implement them for our patient benefit. So many times there are discussions, we may not adhere to guidelines, but we definitely adhere to data.
Yeah, I think well said, Dr. Santosh. I think utilizing evidence-based guidelines is the need of the hour. And not only that, also we run a fellowship program. You run a fellowship program, I run a fellowship program, getting these fellows into the mix of things, running the MDTs with the fellows, make it more educational. And sometimes, there are situations when we involve the patients and families as well, promoting open communications, having, like Dr. Prashant said, very structured MDTs, and Dr. Anis also mentioned, structured MDT meetings is the need of the hour. I think very valid points which you mentioned. Moving on, we have our chair of sarcoma from MD Anderson, Dr. Neeta Somaya, good friend. So what is the situation of video MDTs in the US? In fact, I've had the opportunity and the privilege of WhatsApping you anytime, and you have given those pro bono replies. So video MDTs and inter-country, inter-institutional MDTs, and how do you manage these patient consent, privacy, data transfer issues with regards to this?
Well, thank you. Thanks, Dr. Vishwanath. It's a pleasure to be here. And, the multidisciplinary care is extremely important, especially for rare tumors, right? So that's something that we utilize a lot. I am in a resource-rich area, place like MD Anderson. We have 12 medical oncologists and similarly specialized care in sarcoma. And we, as was mentioned before, can't keep up with the advances in each of our fields. So doing multidisciplinary tumor boards is very important. The video MDTs, I think COVID-19 pandemic has really helped with this, because I can tell we used to have 2 tumor boards, Tuesday, Thursday, for just sarcoma. We discuss approximately 10 to 20 cases per week that requires, multidisciplinary input. And the video format or the Zoom format has really increased our attendance, because we don't have to go to a place and everyone can join in. but the structuring of that is very important. And since we started video MDTs, we've constantly improved. It's actually run by a musculoskeletal or abdominal imaging person. When the list is generated, it is very important to put down the questions that you need, and you present the case, they go over the imaging. We have to have a pathologist, and every, the surgical, radiation, everybody at least sends one representative. So we need to have one faculty present for each of those, so we can have a good discussion and make sure that for each individual patient, we're making the right decision. Sometimes it's even just reviewing the images to see if the response is correct, or what are we really seeing in the imaging. And that has now been expanded. As you can see, when you talk about rare tumors, even in the US, there are areas that are considered resource limited, right? So how do you provide care for these rare patients or rare tumors there? So we have to, this institution called SARC has Sarcoma Alliance, through research and collaboration, has started what we call these multidisciplinary tumor boards that you can submit your case. So again, that's where the HIPAA violation. So the ones we have in our own institution, of course, it's people who are there. It's well attended by, if you have a trainee, all of them are covered, so they can attend. But we can't invite outsiders into our tumor board because we're actually pulling up radiology images. But for the interinstitutional or across the globe multidisciplinary tumor boards, there is a template that you then input data in that is de-identified. So that takes care of the HIPAA issues. And what we say for the SARC is just the person presenting the case, just discuss with your patient that the patient's case is being discussed, so they're aware. And then you fill out this template. Of course, you don't get the benefit of maybe all the images to scroll through, and they're just snapshots of the images. And that, and we need to have lead discussants to kind of go through the case and make sure that the discussion is appropriate, and the person who's who put up the case gets what they needed from that multidisciplinary tumor board. We also have, it's called TARP-SWIG. It's the Transatlantic Retroperitoneal Sarcoma Working Group that has created this global working group for retroperitoneal sarcomas where the surgeons run it. So they're just different formats. And I think this is a great time where, we can bring in these resource limited, LMICs in such a format to present cases so that people can, learn from, it's a bidirectional learning from whoever that participates. So.
Yeah, thank you.
I hope I answered.
Wonderful thoughts. And then last, quick thoughts from you, Dr. Nita, regarding what do you think about AI? We saw Dr. Govindarajan talk so much about radiology and AI. And how do you think it can be part of the MDTs from a medical oncologist point of view?
Yeah. So, I mean, again, I think in places like mine where, the AI is going to be as good as the AI is going to be. So right now, in a place where you already have the specialist, it's not going to be that useful, but I can, foresee in the future, I mean, AI, if it is institutional approved, I mean, it could be great in just like even preparing a case, you can pull out the data and just, present the case easily. AI for pathology and AI for radiology is going to be quite key. And those can be really important in resource limited areas. If you have rare cases, to give you some input. Also, when you're talking about, we just heard from Dr. Growell, like when you put into ChatGPT, you could put in a molecular abnormality that you see, and maybe AI can spit out what's all out there in the literature with the DeepSeek. So I don't think it will replace the humanistic algorithm of how you decide a particular case or treatment, but it can open, it can help you sift through the literature about what's out there. You do need to check it again. So I think this is an evolving field, and as it gets better and better, the AI gets better and better, we will be able to use it more.
Yeah, I think it's all about deep learning, and it cannot replace the human mind. Wonderful thoughts. Thank you. So, Dr. Vinay, quick thoughts about from a radiation oncology perspective, from a low and middle income country, and how do you think participation in MTBs, how does it impact outcomes, and also when it comes to the role what a radiation oncologist plays when we have a lot of centers where radiation oncology is not full-fledged. We just have medical oncology and surgical oncology. How do you think you manage these situations?
Thank you, Asko. Thank you, Dr. Vishwanath, for this opportunity. This question has come maybe 2 decades late for me because, what happened in 2004, when I started, we had only 4 medical oncologists for entire 40 million people of the state. And we radiation oncologists used to manage. How we used to manage, God only knows. And we were lucky that we didn't have too many drugs and we didn't have too many molecular markers to deal with. We had very little chemo drugs like cisplatin, if I remember correctly, adriamycin, things like this. We didn't have so many maps and uh, drugs to deal with. As Dr. Prashant and Dr. Santosh Chapkar put it out very nicely. It's very important how we deal with what we have. So we didn't even have a radiation oncology center to deal with. We had here and there cobalt, and that's all. But we managed. It may not be the best of situation. Compared to now, 2 decades down the line, 2025, we have access to proton, cyberknife, and whatnot, and brachytherapy in almost all the places in tier 1 city. And that is a very good picture, like, Ullas was telling. But the worst situation, if I go just 50 kilometers from my city of Bangalore, we don't have anything. And those people cannot even reach our city. They cannot even come to my place for, say, radiation. So in this situation, the first thing should be to triage the patients. If there is a patient of, say, spinal cord compression, I'm a radiation oncologist. From my point of view, I'm just telling an example. So such kind of patients, first we try to do minimal treatment and send to a place where radiation is accessible. Second example, like Santosh told, I may not agree with him for internalized trial treatment, neoadjuvant treatment. That's a different topic altogether. We can discuss later. But yes, if we don't have radiation center, radiation facility, we would like to give some neoadjuvant treatment, paclitaxel, something like that, and then send the patient to place where radiation is available. In this way, we are not compromising too much on that. Or maybe a case of local advanced or early breast cancer. If you don't have access to surgeon or the radiation oncology, try to do some treatment, some hormone therapy, some chemotherapy, and then by the meantime, patient can get in money, because here the people, not everybody have got access to Dominoes and Daras. So whatever money they collect every day, every month, they get 2-3 months of time. That much money they can collect. They can go to bigger center, tier 3 city, or maybe tier 2 city, if not tier 1 city. So that will be the approach I would put. And then third thing, what I will suggest is we should try to make some kind of a protocol. Like, we had COVID. That is a wonderful level, I'll tell you. We have got, we fast tracked some things like hyperfractionation radiation therapy. That is very important in India. They cannot travel all the way from far off places and stay here for 1.5 months of treatment for breast cancer. So hyperfractionation, fast forward, in which we did the radiation only for 1 week. That's an excellent thing. And we can now also do radiation for 1 day also. So such kind of things we try to educate and get in, so that we do not miss out on the actual treatment for the patients.
Wonderful.
Next thing,
Wonderful.
what I'll tell you is, the last point what I want to tell is, we should try to record whatever we have done and see if it's really we have made a difference to the patients, and try to circulate among our colleagues so they can also follow this and do not waste on the treatment of the cancer.
I think very good thoughts about sequencing treatment, especially in situations where the radiation oncology is not available. You gave very nice illustrations about the same. Thank you, Dr. Vinay. I think that concludes our webinar. I would request Dr. Poonam to give the concluding remarks. I'd like to thank all the elite panelists. It was a very insightful discussion. I learned a lot from all of you, and I'm sure others too. Over to you, Dr. Poonam Moria. You're muted, Dr. Poonam. Dr. Poonam, you're muted.
Yeah. Thank you, Dr. Vishwanath. So as we bring this ASCO Endorsed CPOM Foundation webinar to a close, we extend our heartfelt gratitude to Dr. Julie Grallo, Chief Medical Officer of ASCO, for her inspiring keynote address on the vital role of multidisciplinary tumor boards in the modern oncology care. Your insights truly set the tone for the entire enriching session. Thank you. Our sincere thanks also go to all the moderators and panelists for sharing their expertise and perspectives. Your contribution has made this a truly engaging and impactful discussion. A special thank you to Sarah and Jessica from ASCO for their unwavering support in making this event a reality. Your behind the scenes dedication is deeply appreciated. This webinar could not have been possible without the vision and tireless efforts of Dr. Vishwanath S., co-founder and managing trustee, CPAM Foundation. We also extend our special gratitude to Dr. Srilata Vishwanath and entire board of trustees for the CPOM Foundation for their steadfast support. We look forward to welcoming you to future ASCO Endorse CPOM webinars and invite you to visit us at our nonprofit booth 11037 at this year's ASCO annual meeting. Thank you once again, and let's continue working together to transform cancer care globally. Thank you. Good night.
Thank you so much.